Thank you for joining me virtually for this session. My name is Georgina Kennedy, and I'm coming to you asynchronously from Sydney, Australia to present this work, in which I describe a simple but effective method for augmenting EMR data for deep learning. The premise of this work is that data imbalance is an important challenge in the development of machine learning models. This is particularly true in the clinical space, where we frequently find that the minority class is the class of interest. For example, when predicting mortality or other important clinical endpoints, we're often dealing with classes that are 5% or less of the total sample. Typical methods of dealing with this include over or undersampling training data in order to boost the signal from the minority class. Data augmentation is another commonly used method to work around these severe imbalances, particularly for models that use images as input data. This works well for images and continuous signals, as you can automatically adjust the input data in a way that doesn't destroy its meaning or target class. On the right-hand side, you can see that each of these scaled or skewed images or signals retain their fundamental representation, being that of a cat, and help us to ensure that we are able to detect the intrinsic catness of the image for fat cats, thin cats, cats facing left, cats facing right, and so forth, even if the training data does not cover all of these possibilities. For discrete time series data, however, there's no consensus method of data augmentation. On the right here, you can see a simple example whereby changing the order of words fundamentally changes the meaning of the sentence and therefore cannot be used to reliably train a model. There have been a number of studies that propose the tokenization of EMR data into lists of ordered, discrete event labels that can be essentially treated as language or text, with the benefit of this being the direct applicability of relatively mature NLP classification and prediction techniques. It was our aim to improve performance of this technique by proposing a simple strategy that could be applied to augment discrete EMR data such as this. In order to demonstrate this strategy and understand the effects that it had on model results, we applied it to the MIMIC dataset of ICU admissions for predicting 3 important endpoints, each of which had a different level of imbalance, with the target class varying between 5 and 15% of the overall population. 5 data balancing strategies were compared. First, the input data were used to train the model according to the baseline prevalence, with the expectation that performance of this version would be very low, basically close to random. We then compared a typical basic oversampling strategy to our proposed data augmentation method to see how much of any improvement seen could be attributed to our methods. The ratios in the balanced training datasets were the same for each of these strategies, but in the augmented dataset, every minority class sample was modified each time it was copied, instead of simply being repeated as is. The other benefit of the augmentation procedure was that both the majority and the minority classes could be copied and amplified as long as the ratios were kept as intended. We also tested how time to event weighting affected these oversampling and augmentation strategies. What I mean by time to event weighting is that we assume that the closer a patient is to the time of the target event when a prediction is made, the more extreme is their likelihood of the event occurring, and thus the higher risk that should be associated with their data. For long ICU admissions, instead of time to event, the overall length of stay was used to indicate acuity and therefore modulate the distribution. We wanted to test whether amplifying the signals for subjects with the strongest evidence of deterioration risk would improve model calibration. The proposed augmentation strategy was comprised of 3 steps. First, although we showed earlier that shuffling of language is not typically effective, we can assume that at short timescales, the temporal ordering seen in clinical data doesn't matter so much. We therefore bucketed the tokens into time windows of 1 hour and shuffled the tokens within each bucket, retaining the overall trend towards improvement, deterioration, or stasis, whilst still managing to generate novel training data samples. After this, we randomly truncated the oldest events from the patient trajectory. Because this is not a closed system of care, we assume that many patients would not have had their complete patient history represented in the data, and therefore we want to ensure that the model does not learn simply that longer trajectories are strictly higher acuity, although at a general level this is likely to be true. We then mask a random proportion of labels, assuming that the data process is noisy and frequently incomplete. Here we see that the performance in the test set for those sampling strategies as applied to each of the target endpoints. The area under the receiver operating curve shows that the original data without any upsampling applied rapidly fits to the majority class as expected, struggling to capture much of the data signal at all, plateauing with an area under the curve close to 0.5, so effectively random classification, which is seen as a diagonal line. For the prediction of death in ICU, time to event augmentation and basic data augmentation outperform time to event oversampling and basic oversampling. Likewise, prediction of inpatient death and the least severely imbalanced prediction of task or of long ICU admissions. This also holds, with time to event and basic augmentation outperforming both time to event and basic oversampling strategies. Reviewing the workup to detection ratio shows that for such imbalanced targets, all of the upsampling techniques improve the performance, with the augmentation strategies generally outperforming the basic oversampling strategies across all metrics. The alerts per 100 patients versus sensitivity shows that in order to achieve 50% sensitivity, models trained using the original data distribution have to generate alerts for between 30 to 40% of patients, which is obviously really not at all clinically useful. Where the augmented data can achieve the same sensitivity while generating alerts for 10% of patients or fewer, which has the potential to actually affect clinical care, although we're probably still looking at too high a ratio there for it to be fully accepted. Because of this, the thing we looked at was the calibration, whereby we wanted to know that even if the binary yes-no classification had a certain level of accuracy, we needed to know that the model could discern between those patients that are most severely at risk, returning a 90%, 85% likelihood of an event occurring, versus those that are moderately increased, so say 20 or 30% chance of it happening. This would really allow those basic model results to be actually useful in clinical care. In this set of graphs, we tested multiple simple model architectures across each endpoint and each upsampling strategy. Again, the purpose of this was not to eke out the very highest level of performance possible using a highly tuned, very specific model. Rather, it was just to demonstrate the robustness of our proposed techniques under multiple typical simple settings. Moving from left to right, it's clear that the original distribution produces a model with extremely poor calibration. As we move across, you can see that the stability of the calibration results improves significantly by applying the proposed data augmentation methods, with the most notable improvement coming with the time to event weighted augmentation. This supports our hypothesis that in amplifying the samples from the most high-risk subjects, we can encourage our models to discern between those at severely elevated risk versus those with only moderate likelihood of deterioration, without losing overall accuracy, or indeed more often improving it slightly. We can see that this result is strongly tied to the level of data imbalance, as the top row, which is death within ICU, represents the most significant imbalance and the overall worst calibration. And the imbalance decreases as we move downwards, and at a proportion of 15% target class, even the simple oversampling, which is the graph in the bottom row, second to the left, has some potentially useful calibration results. In terms of takeaways from the study, I think it's important to note what we haven't shown. This method of turning clinical events into discrete tokens and then treating it as text performs well enough in the general case. But for specific prediction tasks, there's often simpler traditional models that will perform just as well or better. We believe it's an interesting method to explore, given the potential to create models that are context independent, requiring local retraining only, rather than precisely mapping specific clinical variables that are rarely generalizable. What we can say with confidence, however, is that viewed through the context of strictly solving the problem of severe class imbalance for discrete data, this technique is very effective. Traditional oversampling methods allow one to boost the signal of the minority class only with a straightforward copy of each minority class sample. Using an augmentation strategy instead allows for more flexibility, where both the minority and the majority class data may be strengthened by resampling each individual patient trajectory in a knowledge-driven fashion in order to create a much richer dataset for both classes. This strategy is common in imaging and continuous time series datasets, but the results presented here show that by making certain assumptions about the data collection methodology, it's possible to implement an equivalent strategy in discrete time series data. The strategy has been designed around assumptions that are relevant to the data entry in the electronic health record and proven against that data. However, there are many equivalent input token-based datasets that may benefit from such treatment. For example, consumer behavior on websites that can be used to drive recommender systems. This is the only method to our knowledge that is driven by known factors of the data entry paradigm as opposed to the data itself, and therefore generalizable across all patient classes and robust to unseen combinations of patient characteristics. In addition, this method is computationally and logically inexpensive in comparison to other generative methods. This factor not only reduces the cost of creating the input data itself, both in terms of how much it costs financially and in terms of time that it takes to create, but it also increases the applicability of model introspection techniques such as LIME or SHAP.